Hello everyone. Now I'll discuss question of respiratory system. So we have a patient named Julie. She's a 65-year-old lady. She has come to you with advanced chronic obstructive airway disease (COPD), and she come to the emergency department with increased shortness of breath and cough for last 12 hours. She took 2 extra nebulizer treatment at home, but no relief of symptoms. She has no other complaint of fever, nausea, vomiting. Well, she has been oxygen dependent for the last 2 years. 45-year packer history is there of smoking, although she quit about 6 years ago. Her medication include albuterol by meter dose inhaler and nebulizer as needed. And remember, she already has taken the 2 extra dose of nebulizer at home. She's also taking tiotropium daily, fluticasone, salmeterol twice daily. All these she's taking. If you look into medication, she's taking oxygen-dependent, beta-2 agonist. She having anticholinergic also, and steroid also. Even short-acting like a SABA and LABA she's taking. Normal temperature, but respiratory rate is 28, very high. And oximetry 84% saturation or 2 liter of oxygen is very low. Okay, and she's dyspneic and in moderate distress is there. She's given additional supplemental oxygen, intravenous antibiotic, methylprednisolone, and 2 treatment of nebulized ipratropium with albuterol. But she still is dyspneic and uses SSC muscle of respiration. The one criteria by which we can know patient in distress is use of SSC muscle of respiration. Well, ABG is of course patient on oxygen therapy now 4 liter of oxygen. Now the ABG is 7.32 pH, 60 is CO2 and O2 is 52. That means severe hypoxia is there. Chest X-ray, if you look into chest X-ray, this shows classically emphysema. You can see the fully distended chest is there. You can see even this lower part of the diaphragm has gone flat, but this is definitely emphysema. The chest is there. Now the thing is, all have been done. Okay, so and in a nutshell, patient has already been given a lot of medication, oxygen, and but still in distress. Now, what the next best step in the management of this patient? Well, the answer is start non-invasive positive pressure ventilation. Okay, what we write as NPPV. So now, before I discuss the question, let me tell you some basic concept about acute exacerbation of COPD. Like our patient, known case of COPD on oxygen dependent for last 2 years, heavy smoking history. Now the acute exacerbation is there. What are the features we talk about? Increased dyspnea, like in our patient, increased cough, increased sputum production. They are the 3 cardinal features. Of course, this is a very, very important point of exacerbation. Now, let's talk about the management part as per NICE guidelines. NICE guidelines say, give oxygen. Target SpO2 should be in the range of 88 to 92%. The patient is already being given oxygen. Inhaled bronchodilator, she already have been given the bronchodilator, and systemic steroid has already been given. Antibiotic and oseltamivir, if influence of, there is evidence of influenza, there is no evidence. And again, this has been given. So now the next line treatment is NPPV if ventilator failure is there, like in this patient is severe hypoxia is there. And taken intubation, even NPPV failed. If you look into this treatment plan as per the guidelines, everything has been done and what left is NPV. Okay, so in our patient Julie, as I told you, chest X-ray revealed emphysema. She's a case of COPD, but no pulmonary edema, consolidation, pleural effusion, or pneumothorax. That means other pathologies have been ruled out by chest X-ray, which is very clearly showing emphysema chest. This patient has acute exacerbation what we write as AECOPD. Why? Because she's in distress. How do you say? She has shortness of breath and cough for last 12 hours, respiratory rate 28, oximetry shows 84% in 2 liters by oxygen by nasal cannula. Okay. Her medication include albuterol, meter dose, inhaler and nebulizer as needed, tiotropium, bromide and fluticon. This was she was taking at home. Okay, but still dyspneic and moderate distress is there. Now she has already been given additional supplement oxygen, intravenous antibiotic, methylprednisolone and 2 meter dose of nebulized ipratropium and albuterol. So as we learn in the basic concept, all these things should be done first. And despite all these things, okay, she's still dyspneic and uses SSC method of respiration, but is alert and follows command. This patient is the ideal candidate to be given that NPPV. Okay, and remember at this moment, despite on 4 liter of oxygen therapy, pH 7.32, COPD, CO2 high, oxygen 52, high, severe hypoxia and hypercapnia is there. So now patient continues to have symptoms despite medical management, should be considered for NPPV. Okay, as your basic concepts are very clear, and we have ruled out why this patient should be given NPPV. Other thing we have done it. So let's talk more basic concept about non-invasive positive pressure ventilation, NPPV. Basic concept. It is a ventilatory support delivered by face mask rather than the endotracheal intubation. Very, very important point. We have not intubated. We are just giving by face mask. It is delivered by different models known as CPAP or Bipap. CPAP is continuous positive pressure airway, and Bipap is bilevel positive pressure airway. Let me show you a beautiful picture. This is self-explanatory, lovely picture, and I'll request you to spend more time. First, we talk about CPAP, that is continuous positive airway pressure. Let me enlarge the picture for your better visibility. What is this? Let's learn more basic concept. Provide a single set pressure throughout the sleep of the patient. More affordable, not as great for accommodating changes in the breathing, constant set of pressure during inhalation, and pressure relief during exhalation. This is a very, very important point, right? So this is continuous CPAP. Again, repeating second time, constant pressure in inhalation, but pressure relief during expiration or during exhale. Now let's look into BiPAP. It is bi-level positive airway pressure. That was single set. 2 distinct pressure setting for inhalation and exhalation. Often used to treat more complex sleep and breathing disorder. So constant set of pressure during inhalation as what we saw in CPAP also. But in expiration, constant set pressure during exhalation also. That is the major difference between these two. That difference lies in the setting in expiration. Well, they are all both non-invasive because look, they are using the mask. They are not putting any tube. There's no tube has been put. That's why we call them as NPPV. This is how they use this continuous CPAP. You see the machine going, and this is the way it has been put, and patient is sleeping. Now, when we use NPP, what happens? It decreases work of breathing, improve alveolar ventilation, and the preferred method for respiratory support in patient with acute onset of COPD, acute exacerbation of COPD. Now, what are the physiological benefits of increase? Decrease respiratory rate and arterial CO2 tension, PA, CO2 will go down. Increase in tidal volume, minute ventilation and arterial oxygen, PaO2 will increase. That means definitely going to improve the ABG status, it will try to bring to normal level. Now, when we use this, what are the advantage? It reduces mortality, intubation rate, treatment failure, length of hospital stay, incidence of nosocomial infection. Very, very important, because we have not put any intubation, but this increases if you put a endotracheal tube. So-called invasive type of the nosocomial infection are very common in the endotracheal tube, and this is not the case when we are using NPPV. Let's look into other options. Administration of aminophylline. Methylxanthine like aminophylline and theophylline, they cause bronchodilation. Yes. They block phosphodiesterase. That means they are phosphodiesterase inhibitors. They increase cyclic AMP. So cyclic AMP level is increased. Do not provide increased benefit over inhaled bronchodilator and steroids in the treatment of AE COPD. But we already have given inhaled bronchodilator and steroids. So there is no advantage of giving aminophylline. Moreover, their use is limited by the side effects. Now stop the video, write down the answer. What are the side effects of aminophylline? Stop the video. Yes, the side effects are tremors and arrhythmias. So there is no advantage. Rather, when we use aminophylline, they are going to may add more to the problem of patients. Okay. Now let's look into option B and C. Quite possible some of you must have marked any of these also, but none of them is correct. B is decreased supplementation oxygen. C is increased supplemental oxygen. Why not? This is really tricky. Well, oxygen in hypercapnic and hypoxic patient should be titrated gradually with the goal arterial oxygen saturation to be there in 88 to 92%. Or PaO2 60 to 70% millimeter mercury. This is our goal, but it should be gradually titrated. Okay. Now, increasing inhaled oxygen may improve oxygenation, but will not address the problem of impaired ventilation or impaired elevated PaCO2. Rather, if you suddenly increase, it can cause further increase in CO2 level, and patient can go into CO2 narcosis. So as I told you, it should be increased gradually, but not. Okay. And decreasing, there is no point in decreasing oxygen, it will lead to hypoxia. Okay. Intubate, as I told you, intubation comes after NPPV. So it may be required in hypercapnic patient. When? Poor mental status, somnolence, lack of cooperation, inability to clear secretion. In such cases, we can go for intubation. Hemodynamic instability, patient having shock, patient having BP, the systolic BP below 90 millimeter mercury, and profound acidemia 7.1. In such cases, we like to intubate directly without going to NPPV. But in our patient, NPPV is the first thing. And if any of these things happen, especially in these two things happen, then we may have to go for intubation as per protocol or guidelines. Well, our patient pH is 7.32, CO2 60. They suggest mild respiratory acidosis. Okay, and or existing chronic respiratory acidosis, not a big problem. We are talking about 7.1 pH. It is 7.32. It is very quite near normal. CO2 is again not very high because normal is 40 to 45 millimeter mercury, 60, not very high. So in this case, as I told you, trial of NPP is warranted prior to intubation. Especially advanced COPD may make weaning and extubation more challenging. That's we know it very well. Intubation, once intubated, its weaning is very difficult. Now, if this patient failed 2-hour trial of NPPV, hypoxemia continues, severe respiratory distress or acidosis, then you can go for intubation, but not at the moment where the patient is fairly stable. Now, golden line to remember. NPP in patient with AE COPD is associated with decrease in mortality, intubation rate, treatment failure, length of hospital stay, incidence of nosocomial infection. Endotracheal intubation with mechanical ventilation is recommended for patients who fail a trial of NPPV. Thank you very much.